Welcome to the deep dive. Today we're cracking open a really fascinating piece of vascular surgery history.
We are. It's a 1975 paper by Malone, Moore, and Goldstone.
Right, the title's a bit of a mouthful. The Natural History of Bilateral Aortofemoral Bypass Grafts for Ischemia of the Lower Extremities.
Yeah, it is. But its impact, still relevant today.
So this paper looked at a specific procedure, the aortofemoral bypass graft, or AFBG.
Exactly. And it came out at a really critical time. Surgeons were actively figuring out the best ways to treat severe blockages in leg arteries.
Okay.
And this study, it provided some of the very first long-term data on this major surgical approach.
So let's set the scene a bit. 1975, someone comes in, really bad blockages in the arteries down to their legs. What were doctors thinking? What were the options?
Well, the big discussion, the main debate really, was between this AFBG procedure we're talking about and another operation called aortoiliac endarterectomy.
Endarterectomy, so just surgically cleaning out the artery itself.
Precisely. You go in, you remove the plaque buildup from inside the artery. And the appeal was, well, you're not leaving any artificial material behind.
Right, which sounds good. Less risk of infection, maybe?
That was the hope, yes. And also avoiding a specific complication down the road, something called a femoral anastomotic aneurysm.
Like a weak spot ballooning out where they made the connection in the groin.
Exactly that. So endarterectomy seemed, maybe a more natural fix.
But there was a catch. A trade-off.
There often is, isn't there? Over time, it started to look like patients who had the endarterectomy. Well, they tended to need more procedures further down in their legs compared to the bypass group.
Ah, okay. So the bypass might have been maybe more durable further out?
That's what the data began to suggest, and that's really where this 75 paper comes in. It took a hard look at how well the AFBG actually held up over the long haul.
Got it. So our mission for this deep dive is basically to unpack what they found, why it was such a big deal back then.
And how it still informs things today, even with all the changes in the field.
Okay, let's get into it. The core findings. How well did these grafts work right after the surgery and then, years later?
The immediate results were honestly pretty stunning. They looked at 360 graft limbs across 180 patients.
Okay.
Initial patency rate, 99.2%.
Wow. That's incredibly high. Almost perfect right out of the gate.
It really was. It tells you something about the surgical skill even back then. It showed the technique itself was fundamentally sound.
So that immediate success must have quieted some doubts about using these big artificial grafts.
I think so, yeah. But the real meat, the real learning, came from looking longer term.
And what did that picture look like 10 years out?
So at the 10-year mark, the cumulative patency rate, meaning the graft was still open and working, was 66%.
66%. Okay, so it dropped from 99, obviously, but still,
Yeah.
2/3 were working after a decade.
Exactly. And for a major operation trying to fix severe disease, that was actually seen as quite encouraging. But what's really valuable is that they didn't just report the number. They dug into why. Why did some grafts fail over time? Why did they clot off?
And what did they find? What were the culprits?
They found significant links, correlations with pre-existing disease, blockages in a couple of key downstream areas.
Okay, downstream meaning.
Further down the leg than where the main bypass graft connected. So one key area was the profunda femoris artery.
The profunda, that's the deep thigh artery, right?
Yep.
A major branch off the main femoral artery.
That's the one. Super important for thigh and leg circulation. The other area was the tibial trifurcation vessels.
Down near the ankle, where the main artery splits into 3.
Precisely. Basically, the vessels feeding the foot. If those were already narrowed.
That would cause problems for the bypass.
Right. But the strongest predictor, the highest correlation with graft failure, that was when a patient had significant disease in both the profunda and the tibial vessels simultaneously.
That makes intuitive sense, doesn't it? Like the main highway, the bypass, is clear, but the exit ramps and local roads are all jammed up in multiple places.
It's a good analogy. It puts tremendous back pressure on the graft, increasing the risk of clotting.
The paper also looked at limb salvage, right? Preventing amputations. What did they find there?
Yeah, crucial outcome. In the short term, an immediate 94% success rate in saving limbs that were considered at high risk for amputation.
That's huge for those patients.
Absolutely life-changing. And looking longer term, the 10-year cumulative limb salvage rate was 85%.
85%, even after 10 years.
Yeah.
That really highlights the impact this surgery could have.
Definitely. It showed it wasn't just about opening arteries, it was about saving legs.
And it sounds like how patients felt afterwards, their symptoms, was a pretty good sign of whether the graft was working.
Very much so. They found a strong link. If the graft was open, patent, patients generally reported significant relief from their pre-op symptoms, the pain, the cramping.
And if it clotted?
Those symptoms tended to come right back. It was a pretty clear indicator.
Okay, but any major surgery carries risks. What about operative mortality? The risk of dying from the procedure itself?
That was another key finding. In this group of 180 patients, the overall operative mortality rate was actually quite low for the time, just 2.5%.
2.5%. So 5 patients out of 180.
That's right. Which, for such a major abdominal and vascular operation back then, was considered very acceptable. It showed it could be done relatively safely in experienced hands.
Now, to get a bit more perspective, we actually have some later commentary from one of the original authors, Jerry Goldstone. What insights did he share looking back?
Oh, his reflections are invaluable. He really paints the picture of that historical context, that intense debate happening at UCSF between AFBG and Endarterectomy.
Right, the debate we talked about earlier.
Exactly. He acknowledges the theoretical upsides of endarterectomy, no prosthetic material, avoiding those aneurysms. But he emphasizes that the data, including theirs, started showing that the AFBG group seemed to need fewer follow-up procedures further down the leg. And that really tipped the scales towards wider acceptance of the bypass.
So, avoiding the artificial graft was nice in theory, but the bypass maybe offered more lasting relief in practice for many?
That was certainly the interpretation at the time, yes. Goldstone also reemphasizes some key takeaways from their 75 paper.
Like what?
Well, the low death and complication rates, even though, as he points out, essentially all these patients were smokers, a huge risk factor.
Yeah, that's significant.
And the excellent long-term results, despite about 40% of the patients having really, really severe ischemia, like rest pain, or even tissue loss before the surgery.
So it worked well even in very sick patients.
It did. And he revisits the graft blockage issue, the thrombosis.
The 4% per year rate?
Yeah, he notes that rate, around 4% per year. And again, hammers home the link to disease below the femoral connection in the outflow vessels. And this leads to a really crucial technical point he stresses, the importance of dealing with any narrowing right at the origin of that profunda femoris artery during the bypass operation.
So not just connecting the graft near it, but actually fixing the start of the profunda if it was blocked.
Exactly. Their technique involved extending the graft down onto the profunda itself, like a patch, to widen that opening. A profundoplasty, essentially.
Interesting. And they did that routinely.
They started doing it more as they recognized its importance. But interestingly, he notes they did not routinely try to fix blockages further down, like in the popliteal artery behind the knee or the tibial arteries, at the same time as the main bypass.
So focus on the inflow and the immediate outflow at the groin.
That was the strategy then. He also mentioned something fascinating about diagnosing those profunda blockages. He pointed out that in their experience, a whopping 61% of significant narrowings at the profunda origin were not visible on the standard preoperative angiograms they were doing back then.
61% missed. Yeah.
Because the standard view was just front to back. You needed oblique, angled views on the angiogram to really see that specific spot clearly. It highlighted the need for better imaging.
Wow, that's a huge diagnostic insight. Any other technical aspects from the original paper that seem, dated now?
Oh, definitely. Medicine evolves, right? For instance, they used a 19-millimeter diameter polyester graft pretty much uniformly.
One size fits all?
Seems like it back then. Today, we know that's often too big. You want the graft size matched more closely to the patient's aorta, maybe 14 or 16 millimeters, to keep blood flow velocity up and reduce clot risk.
And the graft material itself? Polyester was the only option then?
In the U.S., pretty much, yes. Knitted Dacron, a type of polyester. And we also have EPTFE, Gore-Tex is a common brand name.
Is one better than the other now?
Goldstone himself points out there's still no slam dunk evidence that one is consistently superior for aortofemoral bypass. It often comes down to surgeon preference. His personal preference, reflecting modern concerns, is for a specific type of knitted polyester that's impregnated with gelatin and then soaked in the antibiotic rifampicin right before implantation.
Focusing on infection prevention.
Big time. That's a major shift. Another thing, the sutures.
The stitches.
Yeah. Early on, they used silk to sew the graft to the femoral artery. They thought silk was permanent.
But it's not.
Nope. We now know silk degrades over time in the body. So now, for vascular grafts, we use non-absorbable plastic sutures, like a polypropylene, much more durable.
Makes sense. What about how they connected the top end to the aorta?
The paper describes the standard technique then as end to side, sewing the end of the graft onto the side of the aorta.
Still done sometimes.
Yes, if you need to preserve flow down the native aorta for some reason, like to the inferior mesenteric artery supplying the gut or the internal iliacs. But many surgeons now prefer an end-to-end anastomosis.
Cutting the aorta and sewing the graft directly between the cut ends.
Exactly, generally thought to provide better flow dynamics long-term. And another modern emphasis is placing that top connection really high, right up near the lowest renal artery.
Why is that?
To minimize the length of aorta below the graft that could develop disease later and cause problems, get above the common iliac bifurcation disease.
Got it. And were there other procedures they did routinely back then that we don't anymore?
Yes, the paper mentions routine bilateral lumbar sympathectomy.
Cutting nerves in the lower back. What was the idea there?
The theory was it would relax the blood vessels in the feet and improve flow, but subsequent studies just didn't really bear that out.
So it was abandoned.
Pretty much universally, yeah. Just didn't provide a clear benefit and had its own potential downsides.
It's important, too, to remember the limitations of this study, right? It was groundbreaking, but not perfect.
Absolutely. And Goldstone is very candid about this. It was retrospective looking back at records.
Handwritten records, probably.
Handwritten records, exactly. From a single institution. So generalizability is always a question. They used life table analysis for the stats, which was actually quite new for vascular surgery papers at that time.
Okay.
And the way they split the patients, pre- and post-1966, that was a bit arbitrary, mainly driven by a change in their antibiotic protocols.
Not necessarily a change in surgical technique.
Techniques did evolve somewhat over the 15 years, but Goldstone felt they were relatively consistent after 66, which was when most of the surgeries actually happened.
And there was that group of patients who didn't get better, even with open grafts.
Right, that was puzzling. About 9% had patent grafts, but no real symptom improvement. They couldn't fully explain why.
Frustrating.
Very. They hoped to better predict who would benefit, but this group remained an enigma. Maybe misdiagnosis initially. Unclear.
So despite those limitations, the overall impact was huge.
Undeniable. Goldstone concludes, and I think most would agree, that this paper, along with others from that era, really cemented the aortofemoral bypass as a highly successful, durable operation for severe aortoiliac disease. It became the workhorse, the gold standard, for decades.
But things look very different now, don't they? The whole landscape has shifted.
Oh, immeasurably. The biggest change, of course, is the rise of endovascular techniques.
Angioplasty, stents.
Exactly, especially for the iliac arteries just above the groin. Doing those procedures through needles and catheters without the big open incision.
So that's created a whole new debate, hasn't it? Open surgery versus endo.
It really has. Are these less invasive techniques as good long-term? Are they better? The trend now is definitely towards trying endovascular first for many patients.
Which means fewer open bypasses are being done.
Significantly fewer, yes. Which raises another issue.
Training. Experience.
Precisely. Surgeons finishing training today just don't get the same volume of experience with these complex open aortic reconstructions. There's a genuine concern about losing that skill set.
A worry that surgeons might lean towards endo, even when open surgery, might actually be the better long-term choice for a specific patient, just because they're less comfortable with the big open case.
That's the concern, yes. It's a real challenge for training programs and for maintaining expertise.
So is the AFBG headed for the history books entirely?
Unlikely to disappear completely. There will always be situations, maybe very extensive disease, failed endo attempts, certain anatomical challenges where open bypass is the best or only option, but its role has definitely shrunk.
And we still don't have perfect head-to-head comparisons.
We lack robust, long-term, randomized controlled trials directly comparing open AFBG against the various endovascular strategies for the same extent of disease. That's the highest level of evidence, and we don't really have it yet for this specific question over the very long term.
So what's the takeaway on that?
Well, Goldstone argues, and it's a reasonable point, that until we do have that solid long-term data showing equivalent or superior durability for endovascular approaches, the aortofemoral bypass, with its decades of proven results documented in studies like the one we've been discussing, should probably remain the benchmark, the standard against which newer techniques are measured.
Okay, so let's wrap this up. Our deep dive into this landmark 1975 paper by Malone, Moore, and Goldstone really underscores the initial, quite remarkable success of the aortofemoral bypass graft.
Absolutely. That high immediate patency, good long-term patency for its time, and impressive limb salvage rates.
And it also identified key factors influencing how long these grafts lasted, particularly the importance of outflow, the condition of arteries like the profunda and tibial vessels further down the leg.
Crucial insights. This study really provided foundational evidence that established AFBG as a cornerstone treatment for severe aortoiliac disease for many, many years.
And understanding this history, this context, is so valuable for appreciating how vascular surgery has evolved, right?
Definitely. It helps us understand the why behind current practices and debates.
And it leaves you, our listener, with a pretty interesting thought, doesn't it? As we continue this major shift towards less invasive endovascular procedures, what are the potential long-term effects on surgical training and expertise for complex open operations? And perhaps more critically, without that definitive long-term comparative data, how can we be truly certain whether these newer techniques provide the same or better durability as the standards set by procedures like the AFBG, documented so well in papers like this one from 1975?
It's a vital, ongoing conversation in the field. Lots to think about.
It certainly is. Thanks for joining us for this deep dive.